I'm Dr. Eric Moore. I'm a head and neck surgeon at the Mayo Clinic, and I'm here with my patient Heidi, who had a parotid gland tumor and parotid gland surgery here, and we're discussing issues regarding treatment of parotid gland tumors. Thank you, Heidi.
Hi. Thank you, Dr. Moore. So I think we talked about everything leading up to surgery. So now let's talk a little bit about the recovery. And I know that the standard answer a lot of physicians will give their patients is that your recovery period is 7 to 10 days. As you know, I informed you that I did not think that was realistic, and I don't think that's realistic for a lot of patients. And the problem is that if they're not recovered in 7 to 10 days, people start to panic and think that there's something wrong. Mm-hmm. So can you talk about some of the factors that would cause a recovery period to be longer than 7 to 10 days?
Yes, I think, and you and I have had this conversation, I think the disconnect is the definition of recovery, and I think very rationally for most people, that's when am I going to feel normal or get to the end point here? And sometimes I, as a surgeon, am not interpreting that correctly, and I'm thinking, when is this healed up well enough that we're out of the woods with problems developing? The answer to the second part of that, when is it healed up so we're out of the woods with problems developing, is very quick, fortunately, for parotid gland surgery. So we're going to know on the night of surgery or sooner if we're going to get a blood clot underneath the wound or something bad is going to happen that's going to have to require us to go back to the operating room. That's very uncommon, and those things usually happen very shortly. Most of the time, by the time the people are discharged from the hospital the day after or so, and they're going home, they're in this 1 to 2 week period where the chance of them still developing salivary fluid underneath the skin that might have to be drained out, or developing a wound infection, which is uncommon but can happen, is going to happen within that first week after surgery. And by the time we get to the 2 weeks after surgery, we're saying to people, if you had to go back to activity, jobs, things like that, it wouldn't necessarily be dangerous. It might be very uncomfortable. You might not feel normal. You might not have normal movement of your face and all those branches. That may take several more weeks to occur, but we're out of the woods here. Something really bad happening. But then, as you well know and can probably educate better than I can, the time that it takes for you to get over this surgery is much longer than I expected when I first started doing it, and I've come to learn for some people can be months to a year or more after the surgery. What types of things happen in that period? One of the things that we probably don't often spend enough time talking about is how the face feels. Sensation, touching the cheek, touching the ear, putting in an earring, holding the phone up to the face, may not feel normal to people for more than a year after, and even then it may be a new normal for them. That's often confused with the facial nerve that we're talking about. That's a different nerve supply than the nerve that moves the muscles to the face that runs through the parotid gland, the facial nerve. There are many nerves that supply touch, sensation, heat, cold, pressure to this area. Some of them very fine, many of them disrupted during parotid surgery intentionally to get to the parotid gland, and then when that skin is laid back and things are put back together, those nerves have to, fortunately have to sort of regenerate and find a new pathway, and that process is very slow, glacially slow. And so for many people, their face doesn't feel like this side that they didn't have operated on for a long time after the surgery, and for them, that may be very important in their recovery period. The way that the ear feels inside, I have many people talk to me and say, my hearing seems different.
Right.
Well, the hearing, when we measure it with a hearing test and think about how the hearing mechanism works, is normal as far as we can measure it after parotid surgery, and not an expected change. But there are many things that can affect the hearing sensation. And so I think pressure in the ear and around it can make people feel that their hearing is different. Sometimes when we do the incisions in parotidectomy and clean them up, There's still trace amounts of the skin sterilization that we use to clean the wound before we operate on it down in the ear canal. We try to keep all that out of there, but sometimes that can get down in the ear canal, and a thin film can get over the eardrum, and that might make people feel like their hearing is very different. Sometimes there's blood down in the ear canal that can dry, even though we try to keep it out of there and clean it out, and that can make people's ear feel and hearing feel different. So that may not normalize for quite some time. So there are these other things that I think get, on the surgeon's standpoint, unfortunately get de-emphasized because we don't consider, well, that's not a real huge complication of parotidectomy. That may be very important to how that patient functions and feels, that may take a long time to feel better. I finally say to people, parotid gland surgery, I'm describing it. I'm trying to reassure you that the bad complications are very, very infrequent. It's safe, but it's not a little surgery.
Sure.
It's a serious surgery, and on an area that affects you every single thing that you do day to day, and it takes some time for the body to get over that.
So you've talked a lot about swelling being a normal consequence of this surgery. So how long can somebody expect this swelling to last? Like, for instance, is it normal to still have some swelling 3 months down the road after surgery?
Swelling is, again, one of these 80-20 phenomena. So most of it is gone within 2 weeks of the surgery. So we look at surgical swelling in that we don't see a lot of it on day one. It's an inflammatory phenomena, so it's in flux, and the body is forming a reaction to this wound that we've created by parotid surgery, and it's more pronounced on 2 or 3 or 4 days after the surgery. In the head and neck region, for the most part, unless people have had a lot of other therapy and radiation therapy and things for cancer can affect this, but for the most part, it starts to take a drastic turn for the better around day 5, and we start to see decrease in the swelling rather than increase. And then from day 5 to maybe day 10 to 14, a lot of that swelling is going away, to where if you looked at pictures and were able to observe people closely from day 5 to day 14, you would see a drastic change in their swelling getting better. But then the last part of it is a really slow phenomena. So the last part of it, from going to day 14 to normal, might take 3 or 4 or 5 months, and might also fluctuate a little bit. So it might be better one day and then worse after they use their neck a lot or were more active or slept in a certain position or something like that, might wake up with a lot more swelling and then have that slowly go away over a day or 2. So it's not a constant phenomena. It's definitely not the same in every single person. But to say, when is it gone, it might be months.
And what about the people who do have some sort of temporary paralysis? I know that you said nerves take a long time to regenerate. What is a general time frame for those people who might be dealing with that and are concerned how long this is going to take?
We studied it very closely, and I was surprised at the end of that study that it took longer than I thought it was taking for most people. So if people have weakness when they wake up from that operation, which, as we talked about, can happen even in routine parotid operations, it's going to take, on average, 6 weeks for it to start to get better. And it might take 3 months, in the most part, for it to totally go away. And this seems to be also very individual in different people. It surprises us in that we can do an operation and come out of that operation and say, well, that facial nerve is going to work normally because we didn't even look at it. We looked at it. We barely touched it. And that patient might wake up, and I go to see them after the operation that afternoon, and they have some weakness to the corner of their mouth. And it might take several weeks for that to go away. The thing I always try to emphasize is that kind of weakness always goes away. It always gets better. But while you're waiting day by day, you're thinking, this is never going to get better. And it can be an interminable feel for when that's going to come back. And it seems to not come back sort of gradually. It seems to be almost all of a sudden one day it's working very well. So it seems to be very sudden that nerve is finally working. When that happens, we give people facial exercises and things to do. This is controversial whether those do a whole lot or not, but it seems to me that they should help, and that you're firing that nerve and using those muscles, and it gives you some kind of also means to gauge improvement. And we usually teach people how to do those at the time of the operation, and if they do them, great. If they don't do them, in my experience, that nerve still comes back and works normally, but it might take many weeks.
Okay, thank you. So it seems like the aftercare instructions that people are provided after surgery vary depending on where somebody has this treatment. So can you explain a little bit like why the aftercare instructions vary so much? For instance, some people have a drain and some don't. Some people have a pressure bandage, some don't. Some people are told to use a warm compress and some people aren't. So what is the reason behind such vast differences?
The best answer I can give to that is human variation, and on both ends of this contract. So there's differences in how much sometimes people want to know and how much they will absorb and how much they will do, and certain people want to know every single thing that could possibly happen and be prepared for it and have a mechanism. And I've talked to other patients who say, I don't want to hear that, I don't want to hear that, I don't want to hear that. And so I think people adjust a little bit on the surgery standpoint. They try to give people the information that they think they have to know, and then we'll adjust a little bit on the other end of the spectrum. And then so why do the instructions differ? I think that, parotid gland surgery, as we've said many times, goes very well in the end, and probably a lot of the different things that we're doing may or may not make a huge difference in the ultimate outcome. So while some people think, well, I really want people to do this because I found that it helps this, other people might not have discovered that or even believe that or think that it's useful, and so that they might differ in their care instructions. I think that people should ask questions about their care if they're uncertain. I think that's the best advice, is that if people undergoing surgery are uncertain about what to do, or I heard about this person doing this, why are you not telling me to do this? I think they should ask those questions. Surgeons, for the most part, really want their patients to feel comfortable and really want their patients to feel informed, and will tell people, for the most part. I very infrequently would meet someone who didn't want to get those questions.
Okay. So another thing that concerns a lot of people after the surgery is done is, do I need to have scans after this? Because, I'm concerned that the tumor might come back and I'd like it to be caught early. So if I have a benign tumor, do I need to have scans after this surgery? And what are the factors that you would look at to determine whether somebody should have a scan?
The blanket answer to that is no, they don't. And we try to use medical care efficiently, meaning everybody knows the cost of medical care is skyrocketing, and one of the reasons the cost of medical care is skyrocketing is because many times it's delivered by choice and not based on evidence. And so every physician would like to say, I get scans when the evidence shows that it's going to make a difference in this patient's care and outcome, and most parotid gland benign tumors do not recur. And so doing routine scans for a benign parotid tumor is really not indicated, in my opinion, because the cost is not justified by what you're going to find. And so what do I mean by that? If the tumor recurs, for the most part, people are going to know. The patient's going to tell me, I feel something here that feels like what I had before. And it's unlikely that neither one of us are going to have any suspicion. And we're talking about benign parotid gland tumors here first. And that we're going to pick that up on a routine scan that we did and not have some other evidence that it's there. I will have patients come back and say, I feel something coming back. My first reaction to that is come back and see me and let me examine it. And sometimes it's something that I can discern as a normal part of their anatomy or something that should be there, and just allay their concerns and allay my concerns by that exam. If I'm uncertain what's happening, or I'm suspicious but I can't quite tell, or I'm suspicious I think something there, then I will often get a scan at that point to give myself a definitive proof of what's there and not there. But that's very unusual. So routine scanning is not really necessary. Routine postoperative visits, I think it depends a little bit on the patient's location, situation, what they want, things like that. But for the most part, after the parotid gland tumor, benign tumor is taken out, the chance of something bad happening, needing revision care, is very unusual and probably doesn't warrant any routine anything.
So one of the things that makes this parotid tumor journey so emotionally difficult for people is the fact that, you know, the treatment that you have to have is on your face, and you can't hide that treatment area. And so there are some people who may have some effects of this surgery that they have to live with for the rest of their life, and that's very difficult to do. So what advice would you have for someone who is facing that situation?
I think it's very important to try to come to common vision in the patient, the surgeon's part, about what things are going to look like afterwards. And most of the time, this is discussion of terms and what they mean. And I think many times when I say something, the patient may have a very different idea at first on what I'm saying, and we're seeing a different endpoint, and then us coming together and what that endpoint looks like. I think we can do parotid gland surgery very cosmetically. So the probably most important part of the surgery in my mind is adequately, effectively, completely treating the tumor. But almost right up there is the footprint of what I've done by treating that tumor. And we fully realize this is on the patient's face, their most prized part of their body, and they want it to look normal.
Yeah.
And so the next thing I often say to people is, I can't make an incision and have it leave no visible footprint. I can make it very minimal in most circumstances and make it something that if you closely pulled your hair back and looked in the mirror and stared at it, you could always see that I was there. But most people looking at you, and maybe even you eventually during the day, are not concentrating on it. And that's the goal. The other part of the looking normal there is the facial nerve, and I can frequently make that normal almost every single time to where that's not a visible sequelae of the surgery. And then finally, the parotid bed defect. And by that we mean the parotid gland tumor has bulk to it, and I usually describe it as the parotid gland is about as thick as the palm of your hand, and we're going to take part of that out, and so that's going to be missing tissue. And we either make the decision, you and I, that we're going to have a slight depression there, which I think most people after parotid surgery do have a slight depression if we're really critical of it. But that might be so minimal that it doesn't concern you or bother you, or we're going to put something back in there to fill out what we take out, because we can't take out something and just fill it with air and expect something else, to take its place. It's not going to grow back. So that brings into play parotid bed reconstruction. There's many different ways to do this, and I often say to my residents that there's many different ways to do something. That either means that all of them work pretty well in some circumstances, or none of them worked very well and we don't have a better way to do it. And I think in this situation, a lot of them work well depending on what we're trying to do. So for what we're trying to make the parotid bed look exactly the same, and you might say, well, why don't you try to do that in every patient? But I have some patients who are very sick and very elderly and have a bad parotid tumor, and our goal is just to get that thing out of there and get them back on their feet as soon as possible. We might not do a lot of elaborate reconstruction because we might not want to take more time in the operation that would put them at risk or something. But for most people, they want their face to look the same. And so for a lot of people, we do parotid bed reconstruction. And you can do that well in several different ways, and the way that we usually do it is we transfer fat from one part of the body to another, because fat has this beautiful characteristic of it in that it doesn't rapidly go away after you move it around. If you treat it nicely, it'll hold its bulk for a lifetime and hold up to a lot of different stressors, and always using the body's own tissue is better in the long run than using something artificial. So we typically take an autograft, meaning something from the patient, put it to a different area in them. Their body won't reject it. It won't typically resorb. And fat works very well for that if you keep a little bit of the skin attached to it, which keeps its consistency and smoothness and bulk. The other way to do it well is to move muscle around from the parotid bed. There are, I think, strong proponents of both techniques. I actually use both techniques depending on the situation of what I'm trying to do. Muscle that's in the area that you move around is good for small defects, in my opinion, and not as good for larger defects. So it depends on how much we took out and what we're trying to replace. And sometimes moving muscle from one area to the other will give the patient a new sensation in that area you moved it from. So anything you take out or move is going to have what we call a donor site defect also. We're going to cause a problem there. And so we pick the solution that gives us the least donor site defect and the best outcome for that individual situation.
Okay. And do you have any advice for patients who might have anxiety prior to coming back to get a scan? Because obviously, you know, you don't know what the result of that scan is going to be, and people are concerned that their tumor might come back, and that does cause anxiety for a lot of people. So, any advice on how to deal with those feelings?
First of all, I will say to them that they're in very common company, because I think that's just about everybody. The people I talk to say, "Oh, I'm so relieved everything's fine. You won't believe I didn't sleep at all for the last week, and I was all torn up." I don't know how to completely make that go away and how to control our mind. We worry about the future and what it holds for us, and until we're reassured that it's okay, we're going to worry. Try to have some reassuring thoughts to go with it. Is in the vast majority of cases, recurrences are rare. This is why, one of the reasons why I love treating this area of the body is because the outcomes are usually good. So I don't know how to get around the anxiety. I think trying to find a way for them to control their mind as much as possible, just like we do with all anxieties, whether that's meditation or conscious breathing or trying to live in the moment or whatever those things are, to try to control that. But I will say that those are easy to say and very difficult to do.
Okay. And I'll add that, you know, for me personally, I think that having a surgeon or a physician that you know has done the very best for you and that you're in the best and most capable hands is what helps me personally, because even if something came down the road and this tumor came back, I know that you're going to make the best decisions for me. So that is also very important that people have that trust and respect for their physicians, so that if you're in that circumstance, that helps you get through that process.
Yes, I think that might be the most important thing. Knowing that the person you're working with is on your side and wants the best for you is, I think, crucial.